Thank you, Diane, very much. It's great to see you and great to see all of you. I appreciate your grace, generosity, and hospitality and courage in inviting me back. Again, it's good to also have an opportunity to think carefully about a topic in care and critically about something that I spend a lot of time doing, but I don't often get questions and feedback because I'm working with my colleagues. And so an important premise, and hopefully I mentioned this last year when I was talking about cognitive change and aging, is that we all have expertise in this area. So we'll talk about medications today. We all have experience and expertise that informs how we think about things going forward. And with that in mind, I will lean into your expertise and experience in entertaining questions. You notice I didn't say answering questions, but entertaining those questions. And thinking with you about maybe a better way to approach management of these things. So with that, I'm open to your ideas as well. And so I'm gonna grab my slide advancer. I also have a tendency to move around the kinetic energy, for better or worse. So I'll be a bit of a moving target, and I'll try to use the mic, and I'll avoid feedback that might come with those speakers as well. So the title, Medications, Pearls, and Pitfalls, like many things in medicine and healthcare, it's two-sided. It also leads me to tell a brief story about, very briefly, about how I got into medicine and specifically into geriatrics. So my father, who actually lives at Crowsdale, he just turned 86, and he was, and in many ways still is, a pharmacist. And he ran a small pharmacy in his hometown, which became my hometown in Virginia. And I grew up working first as a soda jerk, and then at the counter, and then doing inventory with my brothers, for better or worse, but learned a lot about medications and pharmacy, but principally care of people and what that meant. Given we had no physician in town, no provider at all, he was, in fact, people called him Doc. And he would repeatedly say, no, that's not what I do for a living. Nonetheless, he had trust relationships. And I think a lot of this comes down to that, both what I have been inspired by to pursue my career, and specifically this topic makes me think of my dad and the work that he did. And I got to observe, I had the great good fortune to observe growing up. So we could start with a little bit of an interactive exercise to get you all thinking out loud. And what I'd love to hear is, when you see this picture, or you think about medications, what is one word that comes to mind? Okay. Right, straight to the point, polypharmacy. Fruit cocktail, so yeah, lots of different kinds. Overwhelming, okay. Pill strips, right. So potential ways to make order of chaos. So when you have more than one, you have the potential for drug interactions. Other things. Yeah, so that big spoonful coming out of the box. So a lot of it is the volume of things, and we'll talk a lot about how this has evolved, but I wonder, does anybody have something more on the positive side? Relieving. So medications, and particularly the technology around medications, can do good things for us. Not just extension of life or treating a number, but making us feel better and more capable. Other things? Right. So prevention, protection. So ways that we've developed to treat chronic conditions or the prospect of a chronic condition, to reduce the likelihood of the onset, diabetes, hypertension, all those things. So it's a pretty complex message, right? And one that deserves careful attention and sorting out and kind of a critical approach. So today we'll talk a little bit about what I call the epidemiology of medication use. So that's worth knowing how things have changed over the last number of years. I'd say 30 plus years, 32 years since I graduated med school. A very different prospect. Factors that predispose older adults to medication-related problems. We alluded to this, but that'll be important. Common problems resulting from medicine, so sticking to this theme of what are the risks while we think about the indications. And then an approach that helps us optimize, create a system by which we can make order of the chaos, but also make meaning of it as well. So you all understand this, that medication use among older adults, here defined as adults over age 65, has risen dramatically over the last several decades. So such that right now, older adults on average take 4.5, almost 6, almost 5 medications per person. That's the latest numbers from 2025. You see that that's compared to 3, which we thought was a lot when I was a geriatrics fellow in 1999, but that's approaching a 75% increase, again, on average. That means, and that translates into a substantial number of people who are on a lot of medicines. In fact, we used to define polypharmacy as 5 or more medicines. So a third of people are on 5 or more prescription medications, probably adjusting what our sense of the norm is, because 10% of people are on 10 or more as well. And it means that just about everybody is on a prescription. In this day and age, maybe people would make the argument everybody should be on a prescription of some kind. Nonetheless, we know that that means there are a lot of medications out there. And we know that the most common indications are things that are very common and now more broadly recognized. So hypertension, diabetes, arthritis, cardiovascular disease, all things that deserve attention, but when you start treating and treating according to a guideline, you're going to accumulate medications. I am not going to talk much about supplements. I think that would be a very good talk to go into. Not one that I'm necessarily qualified to give, but something that we deal with on a regular basis, right? Important to know that these aren't counted in that number of 4.6 medications, prescription medications, and that average is about 2.3 supplements per person. Many of these carry strong indications and are advised by providers, things that will improve health, whether it be vitamin D, calcium, multivitamins, omega-3s, B complex. Each of these could have its own slide and own portion of the discussion. The point here being that adds to the mix, and it also adds cost and complexity. On average, monthly cost about $62 per person, or about $700 per year. I saw a person 2 weeks ago, came to me and said, help me clean up this list of supplements, pulled it out, 42 supplements. I said, I can't imagine what you're spending. So factors that lead to increased medication use that are traceable to, I would say, advances. For chronic diseases, more conditions really means more prescriptions. And in many cases, for each chronic condition, be it hypertension, heart failure, diabetes, multiple medicines being prescribed for each of those conditions. Guidelines are pointing providers and systems, and in fact enforcing prescription of certain types of medicines as well. So saying, we expect you, if you diagnose this person with heart failure, then they're going to have 3 medicines. And in trials where that's the focus, people do better. But when people accumulate multiple chronic conditions, these medicines start to bump into each other and interact, and we'll talk about that in a minute. The other is we talked about polypharmacy, and we also talk about polyprovider, as almost a diagnosis anymore, where a person has a primary provider and then a stable of specialists, each managing their organ, their system, and a collection of what they consider to be optimal medications. That complicates things, and when we talk about navigating the system, how those providers talk to each other or not, and how much inertia they have about undoing what another provider has done contributes to this. I worry about stopping a medicine that's been prescribed by someone else. What disaster might happen, or am I just simply going to offend that person? Expectations. So it's almost become an expectation that prescriptions will be the center of a visit in terms of management. And in fact, it often does dominate the visit, both the 10 minutes or 15 minutes it takes to get the list straight, and then the discussions and ending with prescriptions or other things, as opposed to the meat of the matter, which we would hope would be, how are you feeling? How's your function? What are your goals? And then another thing I'm not going to talk about today that I'm sure you would love to hear about is insurance, be it Medicare or whatever supplement or Medicare Advantage. I have a hard time with it as well. And we can talk about ways to manage information around insurance. We seem to be making some strides towards getting medications paid for, certainly compared to 2 or 3 decades ago. That being said, I don't think it's necessarily simplified things, and I'm not sure where all that money is going. So a little bit of science, physiology, that helps you understand some of the productive worry that we should be doing around medications as it pertains to how medications are handled by the body as people age, because this is a critical factor. So it changes, and the example I always bring up is people get put on a medicine, so let's say high blood pressure, right? About my age, people are developing hypertension. They get put on a medicine. They stay on those medicines for 20 years or 15 years, their body's changing, the medicine is not. And so that puts the onus on us, the prescribing provider, to keep track of how the body is changing. So things like how the drug is absorbed from the GI tract, and that changes with motility and the health of the lining of the GI tract, so that you may not be getting the dose that's expected into your bloodstream.
Mitch, I don't know the word motility.
Sorry. Motility is the motion or movement of your gut, including your esophagus, your stomach, your small bowel, and your large bowel. And it actually has little muscles that move it through. And if something stalls and you can't quite get it absorbed, that's a problem. And in fact, as you age, your ability to move stuff forward changes. Can zoom right through, yes. Hey, good point. Hypermotility. Changes in body composition, so as you age, there's more fatty tissue and less lean muscle. And so there are medicines that go and sit in the fatty tissue and then kind of hibernate there and leach out. A drug class that we'll talk about called benzodiazepines, famous, we'll prescribe them. We have listed a duration of action in the big red book, which no longer exists, but and you say, okay, well, the half-life of this medicine is 12 hours, and an older adult could be 2 to 3 times that because it sits in the fatty tissue. Liver function and kidney function, where drugs are broken down, processed, and leave the body, changes in function there that occur with aging or with disease affect the levels of that medication in the bloodstream. So all those things are somewhat predictable but unpredictable in their course and need to be accounted for. So let's talk about some of the risks with multiple medications, because the issue is as you accumulate numbers of medicines, you're going to accumulate to some degree risk of those medicines either doing something to you, that is the medicine having a direct effect on you, or those medicines working at cross purposes to have an interaction that creates problems as well. So we refer to all that as adverse drug reactions. I call them medication-related problems generally. And that's really the drug buildup can lead to some problem or toxicity, particularly those drugs where you have a sweet spot and a little more of it, a higher level of it, creates symptoms and problems. And the exact issue there is drugs are intended to do something, right? So it may lower blood sugar or lower blood pressure, but it can also overdo that. So it can lower blood sugar and lower blood pressure so that you feel faint or weak or what have you. And so that's when we refer to therapeutic margin or index, that's what we're alluding to. Interactions we've talked about, so the more drugs, the more likely an interaction. And then drugs account for, just from an epidemiologic perspective, a large number of hospitalizations and emergency room visits. And that's, again, getting at this idea of they cause problems that can occur particularly in older adults. Examples would be there are drugs like atenolol or phenytoin, known as tenormin and dilantin. We'll have to doubly name every medication, right, or more. They're cleared through the kidneys. If kidney function goes down, the drug levels go up. And so that blood pressure medicine and that seizure medicine can accumulate and cause toxicity. Interactions. So now an old drug, good riddance, Coumadin or warfarin is a blood thinner. Used to be standard of care for atrial fibrillation. Still is because it's the cheapest. The newer medicines are not yet affordable, but it interacts with a whole host of medicines, right? And foods. And so the levels of blood thinning can go up and down depending on what else you're put on. So if I put you on an antibiotic and don't pay attention to the fact that you're getting this blood thinner, then your blood can get too thin or too thick. And then we're going to talk a bit about high-risk medicines and medicine classes that are clearly associated with increased hospitalizations and emergency room visits. So specifically, about 2/3 of medication-related hospitalizations are due to what we call unintentional overdoses, meaning the drug is doing more of what it's supposed to do than is good for that person. And so when you think of high-risk medication classes, we might say, oh, there are all these bad actors that shouldn't be given. But to be honest, this list of medicines is all things that we think do good things in the right dose and with the correct management. So blood pressure medicines is probably the most common thing is over-treatment of blood pressure, or you're sick, you're not drinking and eating, and you continue on the same dose of that blood pressure medicine and get low blood pressure. Blood thinners, so people are very fond these days of multiple blood thinners. Aspirin, Plavix, newer medicines like Eliquis or Apixaban, and sometimes they all get put together in a person who's perhaps on other medicines or prone to fall. So we need to think about that. We talked about diabetic medications and the whole host. It's very rare to see someone on one medicine if they have diabetes. And there are better options other than insulin that don't cause dramatic fluctuations in blood sugar. Nonetheless, people are prone to problems with low blood sugar. And as people age, we intentionally dial back on our goals for blood sugar, make it a little more liberal, let it run a little bit higher, not just to improve safety, but because we know that actually has worse outcomes than better. And I'm happy to talk in more detail about that. Pain medications, non-steroidal anti-inflammatories have a lot of potential side effects, but are often the best, most effective for pain. So walking that balance, and of course opioids. And then this class of psychotropics are medications for emotional or behavioral problems or cognitive problems. And that is a talk in and of itself. So let's go on and talk a little bit more about risks associated with multiple medicines before we move into kind of wisdom about management. So some real outcomes that very robust studies have shown are linked to problems with medicines are falls and fractures. Particularly those, last time I was here, I talked about things that affect cognition, sedative type medicines, or pain medications that can cause sedation, or even blood pressure medicines as well. And in fact, a recent study showed that avoiding what we call sleep drugs, often these are things like Ambien and other hypnotics or even Tylenol PM, that simple intervention could reduce a lifetime risk of fall by almost 10%. And a colleague of mine has done work in this regard on stopping medicines and reducing fall risk at the VA hospital and shown the same. Cognitive impairment or confusion that's often my first question when somebody comes to me with a new concern about memory. What are you on? And often I'll go through, I'll have a student and I'm like, pick out the medicines, and there's 3 or 4 on there that can contribute, particularly the classes of benzodiazepines. So that's Valium and Ativan, among others, temazepam, which is a sleep medication or prescribed often for sleep. But those medicines like Ambien or Zolpidem, the Z drugs as well. There's a whole host of medicines we'll talk about in a minute that have something called an anticholinergic effect. I'll talk about those, but they're often sedating in addition to causing dry mouth and constipation. So we know as well that there are a number of medicines that may result in misuse or dependence if not appropriately prescribed, and so need to be prescribed in a relationship with a person and with clear expectations and goals as well. Unfortunately, often providers aren't necessarily trained or don't have the time to get into or have the knowledge to prescribe these safely. And then things like quality of life. So there's a really good example in heart failure where we know people do better on a class of medicine that lowers heart rate called beta blockers, very commonly prescribed. And they lived longer, people lived longer on the beta blocker, but they felt worse. And it's a little more complicated story, but not much, in that they were like, I feel tired, and low energy and occasionally dizzy, but I ended up doing better with respect to the heart failure. So it depends if you're asking the cardiologist or the person. So we talked about, again, sleep drug use being an important factor both in fall risk and cognitive decline. And we'll talk in a minute about definitions about de-prescribing and how studies have shown that stopping medicines responsibly actually leads to good things happening. A concept called the prescribing cascade. So this is a real case. I don't think I have to tell you that this is when medicines cause side effects that beget another prescription. And this is a real case that we made into a slide, but not hypothetical, in that this person was taking ibuprofen for pain, which elevated their blood pressure. And so as opposed to finding another strategy, a medicine was prescribed for blood pressure that was a diuretic. They had urinary frequency, so they got a bladder relaxant, which had its own set of side effects, including urinary retention. It worked so well, they couldn't go to the bathroom. And so they got a medicine to try to open up. This gentleman got a medicine to try to counteract the prostate problem, which lowered his blood pressure enough that he had a fall and a hip fracture. And these are all commonly prescribed medicines, but knowing that there's this concept called the prescribing cascade, and we're often chasing side effects with prescriptions, as opposed to saying, wait a minute, we're going to think about the medicines and how they may be contributing here. We talked a lot about this list of high-risk medications, so sleep medicines, this class of benzodiazepines that I talked about, over-the-counter allergy and overactive bladder medicines that fall in the category of anticholinergic, so they hit a particular receptor or block a particular receptor, and that causes problems with memory and balance and dry mouth and constipation. And then pain medicines in general. I would point you to, and I actually have a link here, and I'll get you the slides, something called Beer's List. Has anybody ever, this is not there's a pub in Durham, and they have a beers list. And so, not to confuse people, although I would love to point you in that direction, it's named after a geriatrician from the early 90s who developed a list of commonly used medicines that should be used with caution or avoided in older adults for the reasons we've talked about. So that was last updated in 2023 and has a list of medicines and directions and guidance. And then mercifully in 2025, they published a partner document that said, and here are alternatives to be considered. What I love about that alternatives document is only about 50% of the recommendations are medications. So they're saying, okay, if you're having a problem with knee arthritis, then consulting with a physical therapist and doing aquatic therapy, perhaps using a topical nonsteroidal like Voltaren, range of motion strengthening, etc. And so I like it because it introduces this idea of non-pharmacologic approaches.
Mitch, may I tell something?
Please.
I think some of you in this group know that I was on schedule for a knee replacement, and I had PT recommended to strengthen that knee before knee replacement, and it did away with the symptoms.
I should bring a PT with me. In fact, I would say my best friend, there was a point recently where my wife Deanna and I were both seeing PTs and comparing notes. She's better. I'm going to surgery, so we'll see what happens. So I just want to offer this as a great summary of Beer's List. So that is a QR code if you want to take a picture or aim your camera at that. But there's also a link that'll be provided in the slide set. And it's very usable with good links and not overwhelming like the actual article itself, which is 32 pages, mostly tables in 5 font. So we'll not point you to that. Yeah, isn't that magical? I've been trying to animate the dinosaur. Can't quite make it happen. Okay, so let's move from maybe some of the concerning issues to tips for managing medicines. A lot of this is going to be around taking charge of, feeling empowered about ways to get this done. So the first is keeping an accurate and complete list, and you'll probably hear me say that 10 times. An important lesson here is you may make assumptions that your healthcare provider and the system know exactly what you're taking and how you're taking it. We do have a list. I would say almost 100% of the time that list has to be corrected when I see a person. It's part of our process, but they're never perfect. People are seen in multiple systems, have multiple providers, have multiple pharmacies, a variety of reasons, or we run out of time and I don't get to update the list accordingly. And that should include your non-prescription supplements and other things that you're taking, inhaled therapies, injected therapies, etc. This is a hard one, but knowing the list by both names, knowing medications by both names can help with that conversation. Won't expect everybody to pronounce them correctly every time because the shenanigans around drug naming have gotten ridiculous, but still, and important to know that drugs have multiple names. Know the reason you are taking it, and this may seem obvious, but when we go through a list, and often I'm like, why are you on this medicine? I'm on it because you told me to take it. I'm like, okay, well that's fair, but let's go back and figure out what the goal was. Did we meet that goal? And do we need to maybe think about stopping it? No potential side effects. So I will divulge that I have colleagues who say, don't talk about side effects when you prescribe a medicine because they will develop all those side effects. And I said, it's important to be able to empower a person to monitor for those or create an expectation. You may feel this way when you start it. If it's a problem, reach out because I want to know. The only thing the only time I get disappointed is if I don't know or I can't be informed. And this will help me as a provider. And so I think it becomes very important to educate yourself. Now, it is important also to think about what's common and what's not common, because the list, I love the commercials. We giggle, although there's a lot of serious stuff that's mentioned when they roll off that list in the auctioneer's voice of all the badness that can happen. But you should still take this medicine. And then keeping in mind your options for improving medication management. So these are more thinking critically about the meds that you're on as the person taking them. So those that don't have a clear benefit or reason, thinking about maybe we should stop this medicine. And of course, you have to strategize in mind how I'm going to communicate about that. Trying a less toxic alternative that we talked about, I put in there non-medication options, non-pharmacologic approaches are often good alternatives. And then, can it be simplified? Why am I taking this medicine 4 times a day? Is there another approach or way that can get me as close as possible to one disease, one drug, once a day? I think we're way beyond that now, unfortunately. That's like a 1985 quote. So, but thinking about simplification, and there was a great VA study that had a pharmacist who went around and simplified. And medication adherence, meaning people took their medicines with 50% more accuracy when they simplified, reducing pill numbers, moving the timing, taking them at one time if that's safe. So, wanted to introduce the concept of deprescribing. I've mentioned it. This is a thing, particularly in the geriatrics community, where we are stopping. It's probably my most common procedure is stopping medications. But you can't just stop it. You can't stop it. I can't often just stop it abruptly. It requires coordination, tapering. So we have sites like this deprescribing site where we get guidance on how to taper over what period of time. If we're changing medicines, how do I start the other one without overlapping too much or causing side effects, but also considerations of alternatives, those kinds of things. And so we know then there's a mounting amount of research that says it's not just about fewer medicines, that the medicines you're left on, you're probably going to take more often, but it reduces symptoms, so people are better. That often can result in better quality of life. And then I mentioned falls, and there's actually pretty recent evidence that says people fall less.
Is that process there for me to use, or more for you as a physician?
Well, I think it gives you, yeah, great question. So planned and supervised, I underlined, so I appreciate your stopping it. So it would be you have permission to think critically about the medicines you're on and reach out in a strategic way to say, why am I on this? Is it possible we could do a trial off of it and see and have a goal and see how I feel?
A follow-up question, Ken. If you are taking lots of medications and you're like 80, you're right, you're taking lots of medications, what was the question? That's another thing about being 80.
Yeah.
Oh, I know. Do I need a doctor specifically to do that?
Yeah.
Like, for instance, I have a geriatric lung doctor, of all things.
Uh-huh.
But there's a person that's 80 and is taking, I'm taking like, for lots of reasons, I would say, and my physicians have been good. This is not a complaint. But I'm taking lots of medications. Do I need somebody more than, would you think maybe more than just my internist to coordinate that? And should that be a geriatric physician or?
So, great question. Number one, it should always be done in consultation, not I feel like I need to be off this medicine, I'm going to take it out of my pill box. And then number two, who's best situated? Well, I think there's probably a hierarchy to some degree. It's always an important question for the prescriber first, who may know what the indication is and what the problems are with not being on it or being on it. But then the navigation and review of your list, geriatrics were trained to review these lists with a different lens, to think what might be causing problems, what kind of a healthy skepticism, and an understanding of the problems. But number one, the top profession will be a pharmacist or a PharmD. So we have PharmDs, pharmacists in our system who we have access to. They can review medicine lists and come back with specific recommendations based on how the drug is managed by the body, their understanding of the variety of things. Well, I would encourage you to ask. In my system, I have electronic means to have that person drop in, review your list, and no copays have shown up as far as I know, and they send me recommendations, and I'm then enacting those recommendations or negotiating with you. Pharmacist. A PharmD is actually trained a doctor of pharmacy. Eshelman is right here, and most of them come out of Eshelman or Campbell in our area, and we have excellent schools, and so we take full advantage of that. They are important team members. So great questions. So you might say, well, don't you have a list? That's what people come in, and I'm going over the list, and we're finding problems, and they're like, don't you have the list? And I'm like, I need you to bring the list. I need you to manage that. Kind of like you manage your checking account. You reconcile your checking account, right? You got to go over it, and we have to be vigilant about it. I will say a couple options. How many of you have access to your electronic health records and can go on and see your information? Going on there and saying, okay, here's what I really take, and here's what they have me listed as taking. And either printing or taking your machine, your computer into the office and going, and in many systems you can do this online and annotate it, but in the very least printing that list and saying, here are corrections that need to be made, or here are the questions I have about these. I would say that's the most direct way, and either doing that at the level of your healthcare system or your pharmacy, because if I want to know the truth, I go to the pharmacy. So I call and say, when was this last filled? And that tells me the physical pills were put in a bottle and given to you, or hasn't been filled in 6 months. Oh, we probably ought to deal with that. The other is you could take an initiative and create your own. So through the U.S. government, I say this because the link was dead when I went 2 days ago. So through AHRQ and CDC, there's something called My Meds List, and it gives you a little downloadable form, and you can keep it yourself. So if you'd like to keep your own records and want to write those in, then that's another option. Again, I think it's important to know what the system is reflecting, and having the ability to kind of update the system is important. So I'm going to frame this one as how you can help your healthcare team, because this has got to be a shared responsibility. Keep an accurate list. Own that list. Don't make assumptions about what we have on file. Be honest about issues with taking medicines. So a lot of people come see me, they want me to be happy with what they're doing. Some of that means, oh yeah, I'm taking it, so I miss it a few times a week. I'm still a good person. Yes, you are a good person, and I can't do my job, and you can't feel better if you're not taking it. Why aren't you taking it? Why are you missing it? Are you forgetting? Or do you feel bad when you take it? Or is it the size of one of these tables, and I'm asking you to swallow it? So those are things that help inform an approach that can improve things. Develop a system of administration. Now, by system, I'm not meaning you have sorry if anybody does this. I have pictures from my home visit days. Pill bottles on the window ledge, like 20 bottles, and as they're taken, you flip the bottle over, right? And that, that's data, data-driven, but nonetheless, having a place where you can centrally manage them, and then at a glance, anybody taking multiple medicines, you're like, did I take it? did I take that medicine? Or did it end up in the sink, drops in the sink and then goes down the drain? So a pill box or other options. We'll look at some of the other options, but I'll give you my honest opinion about how that happens best. Talk about cost, because we kind of have some complicated mechanisms to have estimates of cost, but it's usually your Medicare Advantage plan putting up a big red stop sign when I'm trying to prescribe and I'm running behind in clinic, and it says, here are 15 alternatives to the one you want to prescribe. And I'm like, okay, I think I can get that. Doesn't tell me how much it costs. So make a note to talk about medicines that you're paying more for and make that part of the conversation. And then think about those symptoms that might be resulting from taking a medicine and or allergies, but often it's about feeling bad because the medicine is having some intended or unintended effects. So there's lots of cool stuff out there for pills. Pill boxes, good old-fashioned pill box is probably 90% of the effort. And that process of filling the pill box allows you to do an audit on a regular basis. There's packaged medications. So these nifty forms of, this is called a med box, where you pull it out and it gives you in a little baggie that you can open by dose. Theoretically great. There's a lot of pharmacies that will package medicines for you. You can also go to Amazon, and I think people have had a good experience. We have a generation that are Amazon users, and to be able to get it from Amazon seems like that's working for some people. There are dispensers. So you see that Keurig-looking thing up there? That's a pill dispenser. I think this one's called Livy. There's Hero. And you kind of put your pills in and then program it. And at 8 a.m., it's like, and it just drops it in like a slot machine. No, I'm kidding. And you take those pills. There's often subscriptions and costs associated with those that could be prohibitive. I'm going to say my big advice is get a pill coach. And that is a person with whom you are living or share time or space, a caregiver, often a bossy child, talking about my wife. And you fill that pill box together and you kind of do that audit together. And that, because a lot of these fixed packaging things, pill lists are pretty dynamic. There's often pills you take if you have symptoms. There are changes in doses, and you have to go back and unpackage and start over. So I think having, in the picture, having someone that helps you co-manage, regardless, and I'm not just talking about my folks with cognitive problems, I'm talking about anyone on multiple medicines, and having a person that can kind of be at your elbow. So I call that the pill coach. Yeah, so that audit is, great question. Audit is my word. So if there are accountants who want to give me a different term. But you have your list, so that accurate list that we've created. You have your box. First of all, you have the apparently empty box, and often you'll go and say, oops, Wednesday morning, that was a bad morning, and all the pills are still there. And so you say both in terms of adherence and then accuracy of that list. And often we've been doing this with my mother-in-law, there are conversations about the medicine and why she's on it. And so that's what I mean by audit. And it's amazing week over week, the kinds of things that we take pills out that may be making her feel worse and send questions to the provider.
Yeah, reordering can be a big issue too.
Yeah.
Yeah.
Yeah, good, yes.
All of a sudden you don't have pill boxes.
Oops. Yeah, running out and reordering. That's a great point. I'll add that to the list. So then financial barriers as well. And so very complex care systems. We're currently in open enrollment for Medicare Part D. If you didn't know, it's always I recommend people go back annually. You have new medicines, but more so, these prescription drug plans change annually. It's a real shell game, is that too negative? In case of how they're paid for and which are preferred. I would say also understanding this can be included in your SHIP counseling, senior health insurance information programming. So in Orange County, it's the Orange County Council on Aging. That's where your SHIP advisor is, and you can reach out and speak with that person, particularly during open enrollment. In Durham County, we're lucky to have senior pharmacists. And if you're going to have somebody come talk about meds, I would recommend Gina Upchurch, my colleague and collaborator, to talk about the process, particularly given her knowledge of policy as well, because that's very important, and the interaction of these Medicare Advantage plans with Medicare, Medicare Part D as well. So those are my prepared comments. I hope it's been helpful to kind of raise awareness that this is not an individual's issue. This is something we all share, that learning how to kind of understand and own part of that process and then make that part of your visit and your communication with your provider and feeling empowered to say, well, I'm on this. Is it doing for me what I need it to do? Are there ways we can think about de-prescribing, reducing, simplifying, coming up with better systems? So thank you for the time, and I would love questions, and I think there's some additional interest in communicating with your provider if time allows. So.
I'm going to use the mic. I was going to ask you about how often you de-prescribe, and I'm so happy to hear that that is part of your health care now for people. I really think that is huge, especially as people age. And then the other comment was about the 4 kind of why people take drugs. And I mean, I would argue that all 4 of those can be managed before the drugs, and would hope that people here would understand that especially the high blood pressure. From my own anecdote, is my mother passed away from early onset dementia at 79, and so at 67 she was high blood pressure. She took 2 medicines, yes, for sure, but as she aged, lost weight, was very mobile because she was demented. I took her off of those blood pressure medicines and she was fine.
Yep.
And I've heard this over and over again, that as people age, their blood pressure definitely normalizes, so to speak, and staying on that medicine could be dangerous for them for falls and having a low blood pressure. And one more thing, so in saying that, how do you feel about the new blood pressure guidelines?
So are you referring to the JNC guidelines? Yeah. Yes. And so, right. So most of these will have a section for older adults. I think number one, it's raising awareness about the link between hypertension and outcomes as a silent problem, and needing to think about it earlier in the process. I think in many circumstances there is evidence to support that lower is better. Often that's done in the context of a clinical trial. And so an example is there are studies that focused on onset of cognitive impairment and blood pressure. And in these perfectly controlled situations, a blood pressure lower than 130 meant they had better outcomes and a blood pressure on average over 130. But then the caveats about perils of low blood pressure, first of all, changes over time, and it's a dynamic issue. One thing that drives me nuts is people say, oh, this is my blood pressure when I'm in the office. I'm like, this is your blood pressure when you're in the office. Your blood pressure is different 5 minutes later, 5 days later, a month later. I need more longitudinal data. So we often are dealing with data that is inaccurate. To go back to your point, I think the awareness of blood pressure and its importance in monitoring and controlling is an important function of the guidelines. The rush to prescribe earlier could have negative consequences, particularly in as much as in a 15-minute visit, it's a heck of a lot easier for me to prescribe a medication than it is for me to connect you with a trainer who can work on habits, particularly diet and physical activity. And we won't talk about GLP-1 and kind of a role for those. But I think your point that lifestyle things often are very effective. It just requires an effort on the part of our system that we're not equipped or incented to do, if that makes sense. I'll point you to actually a very, very interesting called the... Yes. Right. So we've kind of trained, I think I had a point on here about training people to expect a prescription to solve a problem. That's why I pause around GLP-1s and Ozempic and Wegovy, right? But so that's an important, those are critically important points. I'm going to point you all to the U.S. Pointer trial, if you haven't seen it. Recently came out, cognitive impairment and health behavior modification. And it showed in high-risk folks improvement in cognition. So the next question is, how can we create a system where those things are incented, or we put together teams that can deliver that, because it's not physicians who are going to be doing that. Yes?
I think a lot of insurance and Medicare Advantage plans, like you can't hear me. Well,
Thank you. Definitely get me for the camera. No, but I think a lot of insurance companies and Medicare Advantage plans have available health coaches to assist with lifestyle changes and that kind of thing. They don't make readily aware. Right. You have to ask. Right. You have to ask for a health advocate or a health coach.
Yeah, great point. And I certainly am not going to be aware. And I would love to tell you I'm going to look that up. But unless that's passively delivered, it's going to be hard for me to say. It's enough for me to say United, Humana, Aetna. Which person am I going to have to do a peer-to-peer consultation to get prior approval to do X, Y, or Z? So complex by design. So maybe their intention is we not take advantage of these things, but I think you can empower yourself in knowing those additional advantages, yeah, or benefits. Good.
I have a non-medication question,
Okay.
which may be illegal right now, but anyway, it's about hydration.
Mm-hmm.
And what I have read long ago and seems to continue is 8 glasses of water a day. But I have also read that doesn't apply. That was inaccurate. And whatever the number is, it's got to apply to the individual, your size, your activity level, etc. So there isn't possibly one size fits all. And also, does it have to be water or can it be fluids?
Right. So great question, and this is something we grapple with because it's an area where people want me to tell them how much to drink. And you're right, it's kind of ripe for research, but it is also not, there's not a dose because we know, I can tell you there's an epidemic of dehydration, number one. So I'm always of the mind more is better than what you're doing now. And often I will say the best metric here, and I will use directions like, okay, 12 ounces at every meal, and then 12 ounces once between meals to get people headed the right direction, right? So that you're pushing 60 ounces, that's certainly better. I also say, I don't say water exclusively. I'll often say non-caffeinated, low or no sweet sugar or sweeteners. You can choose whether you like something fizzy or not, if that makes you more likely to drink it. Just know that sometimes that is acidic and it can cause some bladder irritation. But that if that gets you to drink more, then that's great. The approaches So the hardest situations are who's going to prompt you or remind you to do this. So people are sometimes good about carrying a big jug around. I mean, the jugs these days are absolutely, the med students are on rounds, and I swear there's like a keg that we're taking room to room, which is great, right? Because when I was a resident, of course, my kidney function was terrible. And so what I say is, okay, here's something that sounds weird, but this is what I need you to do. When you go to the bathroom, when you urinate, I want you to look at the urine in the commode. And assuming you don't have a commode from the 70s that's this color, I want you to get that to run clear or near clear, a light straw color. That tells me you're getting it done. Now, as providers, this is a key point that I teach. You also have to take a step back and say, okay, you're going to ask them to drink more fluid. What are they worried about? And of course, I'm worried that this is going to make me have to go to the bathroom. And I'm not going to pound water before church or at bedtime, or I'm just going to restrict because that's a matter of convenience. This is not scientific, but I have found that if you're hydrated, that urine in your bladder is going to be a lot less irritating to your bladder. So when you hydrate, your urine is more gentle on your bladder because of the chemical content, the pH, etc. And so it actually counteracts, but it gives permission. You say it's okay if you don't drink water after 5 o'clock, but make sure you dose it before that, or drink what you will so that you're done at 5 o'clock, and then maybe that'll get you up less overnight. So.
Are there any guidelines for, like, if you're 120 pounds,
Right.
or if you're a football player? I mean,
Or you're on a diuretic, or that's the big thing.
how do you know what is
Right,
right?
right. I'm sure that some of my colleagues, particularly nephrologists, or even some of you in the room, would have better ideas about advice that you've gotten in this regard. Again, there are issues with aging. People lose their drive to drink, to have thirst. Their thirst declines, and that makes them fall behind in that regard. You just don't have thirst that's going to drive your sense of a need to drink. Your body's not going to take care of it. So yeah, I wish I had better advice. I could say most people are dehydrated and need to increase their fluid intake. Yes?
Not be good for certain medications?
So grapefruit, so theoretically grapefruit juice can interact with certain medications and affect levels like certain antibiotics, erythromycin being an example, and can affect metabolism. And so it's worth putting into the interaction, or you share with your prescribing provider that you drink grapefruit juice on a regular basis. There have been subsequent studies that say you would really have to drink a lot of grapefruit juice for that to play out at the level, the chemical level, in terms of those interactions. But always good if you have something that you do regularly. So this goes for foods and fluids. So there can be interactions with foods, as many of you know, with medications, both in terms of if you take stuff together, the medicine may not be absorbed. So if anybody takes a bone density medicine called Fosamax, you got to take it on an empty stomach, wash it down. If you're on thyroid medications, and got to separate those, particularly from calcium and other things that can bind up medicines. If you're on Parkinson's medicines, you got to be careful about how you take that with food, and particularly protein. We need a pharmacist because they have that particular knowledge, and they become an important team member in that regard.
Do you have an opinion on turmeric for arthritis?
Yeah, I don't have a strong opinion. I know a lot of people take turmeric for example, in my clinic, for memory. And there's some studies to say that turmeric can help with cognitive performance. I'm less certain on those anti-inflammatory effects and their effect on arthritis. but I'd be happy to look that up and learn about it. I think I always like to know that somebody's on turmeric, because if I have them on something that's metabolized through the liver, I always want to keep track. There are enthusiasts who will, take tons of turmeric that ends up being problem, or they take a pill of turmeric and they can accumulate that quite rapidly if they take it in large amounts. So just knowing kind of what the potential side effects are. But I don't unfortunately have for you a strong opinion or advice in that regard. Turmeric, I do it. So I do it in my coffee. My wife does it, so I figure I better do it as well. Your liver's good, and you're taking it in a reasonable, and it's as a food additive. It's going to be hard to get it that much. If it's packed into a pill and you take 8 pills a day, that your liver may get unhappy. There's a mic.
Oh, okay. I'm loud, but what was it? Oh, this one. I take a number of vitamin pills along with my prescriptions, and I've heard, this is just what I've heard, and I just wonder if you respond to it, that if you're taking too much vitamins, like you're taking a multivitamin that's got calcium in it, and you're also taking a calcium pill. You're taking a multivitamin, but you're also taking B12, D whatever. What I've heard is your body's just going to kick out what it doesn't need.
Yeah.
So in some respects, it would be better if you could afford it to take all those vitamins and then let the body kick it out.
Yeah, there's different perspectives, right? At best, you'll pee out the extra. But I think the more important point is that understanding what are your goals. So this is the way if I'm looking at a list of supplements or vitamins, I'm like, what is your goal? And are there ways in which we can address this goal more directly? Often it's about memory or other things. And then can I ask you to go over those labels and reconcile the different medicines like calcium and vitamin D? Some of it's about cost. Some of it could be about toxicities of accumulating a large number of things. So if you have St. John's wort in 5 different medicines, for example, as a hypothetical, you could get toxic on that. So, We still good, Diane?
A quick question about probiotics. Do you think they increase the GI system's ability to absorb medications?
That's a good question that I don't know about medication absorption. I would think that there has to be a relationship between, I'll put it up there, gut health, right, and medication absorption. I don't have a working knowledge of a study of the specific interaction, particularly with a particular probiotic. I would say in the setting of conditions or problems that may result from alterations in the gut biome, that it would make perfect sense to me that it would help with medications. And I know those linkages I know when I was last here, someone asked about gut biome and cognitive health. There's a lot of great work going on to make what is likely a very real connection. So I would be inclined to say, examining the choice of a probiotic and kind of saying, okay, that's a safe one that's doing for me what I want it to do. It'd be hard for me to imagine it wouldn't help, but it's a question worth asking.
2 quick comments. One on hydration. I was advised to shoot for half your body weight in ounces and to try to do that frequently during the day rather than in one big sitting or several. And the other comment is when you get your medication list adjusted and right, be sure and put it on your refrigerator in case of emergencies.
There you go. Yeah,
EMTs
the little
are gonna
vial
ask
should
for
have
it.
your medicines in it. That's a great point. Probably with like 5 minutes. I've got to run an errand to Carborough. Oh, yeah. I think Diane had let me know that folks had some questions about communicating with providers. And so I had a few points to make. If you're so inclined, if that would work. Thank you. That's wonderful. I think the caveat in these comments is our healthcare systems are struggling right now, so that's important to be transparent about. With reductions in resources, if you're at UNC or you're at Duke, et cetera, doing more with less, particularly at the level of primary care. So it becomes then, I think, critically important to think about this as a shared relationship and ways to optimize the yield in a given visit. Because if I go into a visit with a passive approach, a very busy provider might say, oh, great, we don't have much to address, so we'll get you your vaccines and or screening tests. Have a good year. For those on Medicare, you have the opportunity that's presented by the annual wellness visit, but that's really geared towards what Medicare wants, so that's pretty checklisty as well. So thinking about then how this is a partnership and how you can get the most out of healthcare visits, I think is important. And it's different than it has been in the past as well. And that goes with how we use the time and then the team of people that you might be communicating with. An important concept at the primary care level, and this may differ by practice, is you may have a primary care provider identified, but more and more I'm advising people to look at the practice and anticipate that you're going to see different people in that practice. So you want to know that that practice has some cohesive communication systems, that you want to know about the whole practice in terms of providers, who you might be seeing, physicians, advanced practice providers. And so I often will say, here are practices that I think are geriatrics friendly, and you may see an advanced practice provider or a physician, likely both. So I think, and I see it as a big bonus if those practices have close working relationships with other professions. So if they have a pharmacist on site, for example, if they have a social worker on site, if they have a financial care counselor on site. So those would be kind of practice assessments that I would have you think about. It's not really anymore you're going to walk in and sit down and talk with a physician and get all that stuff done, that it's usually going to be a team approach. So, and I think I shared an NIA resource, which is, the link was active, so we probably ought to run and get it and download it, which is, as an older adult, talking with your provider. I think that's a great resource for thinking across things. But a few points that I would have, think about and prepare for the visit. Read the last note from that person. And they often will give you an after-visit summary, but go read the note and then you'll know what they are thinking and what the goals are and how you can help them understand, did we achieve those goals? It'll also tell you, they left out my shortness of breath or my ankle swelling, and so I need to make sure that that is on the list this time. So it gives you an idea of any disparity between what you are thinking and what they are thinking, and then helps you put together the list of concerns or symptoms. I think, again, accounting for time and pressures, thinking about how you're going to tell that story is also important, because context, I love context and I love stories, but oftentimes I have to interrupt your story, particularly if it's starting, well, back in 1975, and I'm like, I think so. Thinking about the context, and again, as I say, context is important, but kind of, here's my list, shortness of breath. When does it occur? What are the situations? Lying down, standing up, exerting myself, how far can I go? Over what time period is that evolving? What am I worried about? What makes it better? What makes it worse? So you can go kind of from a symptom perspective as well. But it's also okay to introduce larger concerns. So with these diagnoses, let's talk about the big picture today. And to me, this is critically important because this is the thing that gets squeezed out. My goals and preferences for care. What are we really trying to do with this statin drug when I have this new cancer diagnosis, right? And so I think often it's important to create those permissions as well. I think as the other, and I'll get to your question here shortly, the other thing is in thinking about the visit, and I know I struggle with my dad on this, is I used to offer to go, hey, if you need me, Dad, I'll show up, I'll meet you. I mean, I work on campus. I can walk over and meet you at clinic. And he's like, I don't want to bother you, and maybe I just don't want you there. This is my gig. But emphasizing that if you have another person listening, first of all, you hear two people hearing the message, reading the body language, asking additional questions, taking notes, keeping track. That's incredibly powerful. And I think so thinking about who that other person might be, right? I talked about a pill coach. So I think about who your companion can be and whether you can also give that person access to your health record. Not to get nosy, but to kind of help you with what can ultimately be a lot to do. Big questions come up around electronic communication.
Oh my God.
And so, very honestly here, at the end of a long day when you have 30 messages, it's often very hard to go through and say, okay, I'm going to answer all those messages. It's an important part of what I do, and creating space for that is something we're still trying to figure out. I would say that same approach, if you're going to have a message, make it focused. Make it focused. I do not want to disincent anyone from sending messages, but just think about the purpose of the message, and then know that often there is a triage person who's going to read that first, and they may be able to address it, and then they can pass on a focused question to your provider, and you're likely to get a much clearer reasoned response. Again, if you keep it very kind of clear, reasonably short, and get to the specific question that you have. I'm going to pause there. You have a question.
A thought from what you were just saying.
Yeah.
The systems are actually, though, making it harder and harder for us to ask a specific question, because like the UNC system and Duke's to some extent too, they limit what you can ask. You can ask about last month's, or you can ask about a prescription, but you can't say, I'm anxious about something, I needed to tell you this, which we used to could do, and somebody would respond. But the other thing I was thinking about when you were talking about managing your situation, and I just wondered what you would think about this. Anybody that's got a lot of age on them and a lot of medications, they should be seeing their primary physician at least 4 times a year. I mean, would you see somebody mine will, but would you do that?
It can be a challenge. So I know that I will ask for a 3-month appointment, and then I get a call and they say, your next available is 2028. And I'm like, okay, well, we probably ought to see you sooner than 2 years. It's a challenge,
I'm really talking about, though, in my suggestion just to people, because I found this true. You can get a 3-month appointment. I mean, with my internist, you can. I mean, I go in and I say, okay, when are we going to meet again? They're going to say 6 months if I don't say 3 months. But then she says, okay.
And that may be, and often addressing things more frequently can be easier and more efficient. At issue is also being prepared to say, okay, well, we may have a practice model that says, you may not see me next, you may see a nurse practitioner who works with me, and you can go in and see that person. And particularly if you have a follow-up, like how's your blood pressure doing, or how are you doing off of this other medicine, or did you have a study, like a sleep study, that we just need to follow up and make sure that that comes across. So that's a model that I think there are a lot of advocates for. And it's not, I like working across professions because, say, the nurse practitioners in my practice bring a different lens to it than I do. And often they will have ideas that I'm not going to have by virtue of having clinical practice experience in nursing. And so, and there are many ways in which that can be a bonus. Not just say, let's get you in, not just to create space, but actually optimize care.
Mitch said 15 minutes ago that he needed to leave in 5 minutes. Mitch, thank you so much.